So what do you think actually happens if people pay attention to the symmetry of their face? How it like correlates with the quality of life? Like what would actually happen?
I think there's a lot of insight that can be gleaned from that. And it's one of those things, just like many other things in life. It's just once you see the pattern, you can't unsee it. And then you start seeing it everywhere you go. It's like the red car theory. But then you start having this better understanding of, oh my God, this is so prevalent. You start seeing it so much that, sure, part of you is like, this is so common. But then you start like noticing how people move and how their facial symmetry kind of shapes how they walk and things like that. And then, depending on how comfortable some people are more like extroverts, and they'll be like, so do you have this issue? Because they're kind of basing it on what they've seen with the facial asymmetry. And you start seeing patterns. And the other thing that you start seeing after that is some people check all the boxes and some people check none of the boxes,
Mm.
which really, to me, the reason that happens is the whole like adaptive range concept that we've talked about. So the way I try to explain it is an adaptive range is basically what's your capacity for dealing with things that are physically less than ideal.
Do you-
If life is going well, you have good relationships, good support system, you don't have like external pressures more than normal, or you feel like they're within your capacity, then you have a much higher ability of dealing with things that are less than ideal in your body. Like I think I've told you this before. It's like twisting your ankle. You're twisting your ankle on a rainy, cold day, and you either hate rainy, cold days, and you're going to a job you hate, and you twist an ankle. It's going to hurt a lot more than twisting your ankle going up a summit that you've been dreaming about for 10 years because it's one of the most exciting vacations of your life.
how do you apply this to the face?
Um, Basically, the more asymmetrical a face is, the more is going on there. And it usually kind of works its way down the body. So you see some people that are like, you look at them and in the beginning, you start assuming you must be in a lot of, suffering. And some people are, and some people aren't. So just because the physical body is not where it needs to be, there's a huge component to the mind aspect. Because if your mind is right, you can overcome anything. But if your mind is not where it needs to be, the smallest little inconvenience makes you implode.
So how do you think facial symmetry or asymmetry, how does that reflect downwards to the rest of the body? And what does that correlate in terms of like symptoms?
Um, you will have, especially the people that are really asymmetrical, um, typically what we see is they will have like one-sided symptoms, as in my right shoulder is the bad one and my left hip is the bad one. So it will typically be, for most, more on the extreme side of torsion or facial strain patterns. They'll have a shoulder that's more off, and sometimes they don't think about it until you ask them, and they kind of have to pause, and they go, "It's both." I'm like, "Well, I didn't say it's not both, but which one is really worse? The one that really gets you?" And they go, "Oh, yeah, it's this one." And then you going down, downstream into the rest of the body, and I go, especially if they're older, so they've had more time with this. Like, do you have one knee that's worse than the other? They're like, yeah. Well, then it'd be like a lot of times, right shoulder, left knee. Oh yeah, I had to get my left knee replaced because there's so much contortion. Now they're pressing more and putting more weight on that one knee, and it just increased accelerated the wear and tear on it.
What does that have to do with the face?
So if someone's face
Hmm.
is asymmetrical, one eye is higher than the other, one ear is higher than the other. Smile line a lot of times is parallel. So if this is this way, then the smile line is this way as well. Well, what's happening is the sphenoid bone inside their skull, which is like the centerpiece of the skull. It looks like a little butterfly shaped bone. Well, most of the time, the sphenoid and the hip are parallel. So if your sphenoid is lower on one side, then your hip will tend to be lower on that same side. And that lower side of the hip is the one that's going to have more foot issues, more knee issues, because you're putting more weight and you're finding the ground more with that one foot. So you have asymmetrical wear.
All right, so the skull symmetry, where the sphenoid bone is in the middle of the face, that correlates with hip symmetry, so the stance.
Yes.
And does it cause spinal rotation issues, scoliosis, anything like that?
Very much so. And the scoliosis is one of those where if this is caught younger, it can be improved greatly. You can never say fully reversed, but it can be greatly improved. Now, someone who's been dealing with it for, 50, 60 years, it might not fully go away, but at least the symptoms that are associated with it, because if you get things aligned better, then the fascia relaxes and they're able to just have a wider functional range.
So how does it get corrected when someone's younger, the scoliosis?
Usually because things are just not as much set in place. In terms of the oral approach, it's pretty much similar, sure, a little faster, because their body just responds faster. I mean, think about pulling an all-nighter when you're 19, 20, 21.
Yeah.
You just go on about your life.
Yeah.
If we pull an all-nighter, there's a price to pay. So their body responds faster. Basically, we try to get the facial symmetry, and then they work with a PT that can try to help the rest of the body kind of respond and keep up too, because you're fixing one aspect of it, but if the habits in the rest of the body are there, well, they need to be fixed, because as well as your body knows, it's still a creature of habit. And if you don't intentionally fix those habits and posture, defaults, then it just won't improve.
So you're saying fix the skull to fix the posture?
Yes, absolutely.
Fix the skull to fix the posture. So,
Yes.
So this is not a concept I've ever learned. So from a dental perspective, like how do you fix skull and symmetry to fix the posture?
I mean, the short version of that story is we need to put intermittent cyclic low force pressure on the low eye side. What that means in so many words is we don't want to brute force the skull into submission. We're doing it very gently, and it's done with an appliance. And I say appliance because there's multiple ones depending on what other things we're trying to fix at the same time. So I've come up with a combination appliance that does some jaw growth at the same time. So if someone is narrow and they're asymmetrical, we'll make one appliance that can do both. If someone has a pretty good size, albeit that's quite often rare, but it can be done with something like the open loop. It doesn't give you as much growth, but it gives you the facial symmetry. So basically, it'd be an appliance that's worn for somewhere between 8 and 12 hours a day. And it just has this block, which think like your appliance only touches on one side. And it's typically the low eye side because we're trying to kind of push it up and give some free space on the high eye side to kind of drop down until the person levels out.
What's a low eyesight, high eyesight?
As in, if your face is asymmetrical like this,
Oh, okay.
then this is your high eye side and this is your low eye side. And then the ears are typically the same thing. So you kind of stand straight, and we have a picture with a grid. And even if they're standing straight, because some people without the grid think, oh, it's just because I'm standing funny. But we put them on the grid, we line up their head, and even though they're lined up on the grid, their ears are like this. I was like, yeah, it's not your posture. That's just, the posture is typically the opposite, interestingly, because what happens with this is you will tend to stand like this. And the reason is because the sphenoid is intertwined with your balanced vestibulocochlear system. And that's what your head defines as level of horizon. So it tries to level out the horizon so you can walk and move through this life balanced.
This is the reason why I have symptom of vertigo and dizziness.
Very
Balance.
Very, very possible. I mean, as you already know, there's multiple reasons, but if someone has been to an EMT and they've checked everything, they're like, well, crystals are the way they should be and everything else. Well, it could be because you're fighting an improper posture to try to compensate for something that...
I mean, the other thing is, I think, arguably, like crystals and stones in the semicerebral canal, that's also contributed to by sphenoid asymmetry.
Yeah.
And we get stuck.
Yeah.
And you get vertigo. All right. So if I were to look at someone's, I'll give you an example. The first person that comes to mind, like a celebrity, is like Clint Eastwood. It's like, could one eye sock. That's right. And if he smiles, it's very crooked. Lyle Lovett's another guy. Has really like crooked smiles and stuff.
Yeah. Morgan Freeman.
Morgan Freeman, yeah. Yeah.
I think he has, actually, I think he has.
He has diagnosed fibromyalgia. So this brings me to the cause of the fibromyalgia. This fibromyalgia, we often see facial abnormalities, and especially with retrognathia, which is really retracted jaw, but also like very specific like fibromyalgia features, almost this sort of triangular like shape of the face, and also the neck comes forward. That's a lot of people with fibromyalgia, and it's almost as like look at someone's face and see that they're in pain. Now, fibromyalgia has changed words. Do you know this?
No.
All right. So a lot of people see fibromyalgia, but the new age world is called dysautonomia now.
Interesting. So now they're same thing?
It's not. They're very similar. I would say fibromyalgia.
They go hand in hand?
Yeah, they go hand in hand because they traditionally have different pain points. They have autonomic dysregulation, right? And then the tension points are the fascial tension points in the head and neck, and then the body, the hips all the way down. That's basically preventing them from going into like a full C. And so you get the tension points around the brows, the TMJ, behind the ears, all the way back down, sternocleidomastoid, the scalenes, the traps, shoulders, behind the scapula, like all the way down to the hips, et cetera, et cetera. And so, this fibromyalgia is trending down, and dysautonomia is trending up.
I can see that versus my social media algorithm, but it thinks I'm interested in certain things as well. So there's that.
So, I mean, if you're an ER doctor listening to this, ER doctors are now seeing a explosion of this dysautonomia. But like a fibromyalgia flare, that's come way down. In fact, they only really hear fibromyalgia flares in people who are generally older, right? 70s, 60s, 70s. And then the young population has switched terms. And the term switch has nothing to do with diagnosis. The term switch is whatever is viral right now. And dysautonomia in POTS is called virals along with massive activation. But these are manifestations of what actually happens when there's issues, like actual physiologic issues in terms of structural issues. Because, I think, I'm internal medicine doctors, internal medicine, we get too obsessed with the internal. We get too obsessed with the chemistry and the biology. But we know very little about physics, right? Versus orthopedics or maxillofacial surgery, dental, physical therapy.
There's a mechanical component.
Yeah, there's a mechanical component. And so there's always been this rift between a mechanical external component versus what we see internally. What we see internally is blood sugar, blood pressure dysregulations, heart rate dysregulations, chronic pain. All these things kind of fall under that fibromyalgia spectrum, as well as dysautonomia spectrum. But more and more, we're starting to see people who are hypermobile. Hypermobility, which is elasticity in joints, connective tissue.
So that's what most people call like double jointed, basically. It's like, oh, I look at this cool body trick.
Well, that's one type.
Okay.
The other type is that they can't move it at all. That's because when they were younger, they're so hypermobile, the fascia has to contract to lock them in place. So that's the hypomobile type, right?
Interesting. So if someone is watching and they're like curious, well, I don't know if I'm hypermobile. Like, is there something quickly that can be done by a person? It's not a diagnosis, but it gives them an idea. Do I fall possibly under this category?
Yeah. So one of the things I see, they can touch their thumb to their forearm. I can't do it.
No.
I should give my kids are hypermobile. I should get them to come in, right? Or how far can they bend their fingers back here? It's as far as it goes. A lot of people can get bend like really, really far, right? Or like my elbows are pretty straight. Some people were like, all right, it turns out work. Right?
Or they can go beyond straight, like their palm goes down further.
Exactly. And then they can have them twist all the way around. My youngest could go all the way around, like a 360, right? Yeah. Hypermobile family on my wife's side.
my wife is hypermobile, and I think my son is hypermobile as well. So even at 7 years age, you know what's sad about the fibromyalgia part? In dental school, when you get started, they just get you started on like learning things, and then they eventually just give you the basics, and then start trying to correlate it with clinical things to teach you how to function in the real world. And fibromyalgia comes up, and the doctor looks at us and those teaching and goes, if you see that, you'd better be careful, because that's a trash can diagnosis. Essentially, avoid that patient because they might be crazy.
Oh, that's true in med school too, because
It's like, be careful what you tell these people. It's like,
yeah.
this person is suffering, but it's sad.
Well, I think it's when you medical dental institutions don't have a very specific answer to something that's easily accessible.
That falls under the no drugging or cutting, but ignoring, like DCI.
Yeah. Well, but the thing is, like, my mom's acupuncturist. She loves her mild patients because they get better. And so with acupuncture needles, you're addressing the external component as well as the internal component at the same time. And so, like, fibromyalgia has been in my vocabulary since before med school, because like, that's what a lot of my mom sees. And so actually other diagnoses too, whether it's like neurological issues, MS, Parkinson's, she sees a lot of these patients, and she'll love them. And then when I get to med school, they're like, oh no, we can't do about it. I'm like, well, that's not what I grew up with. Right? And so, I think that this, if we break down the words like fibromyalgia, like fibro is some sort of scar tissue, myalgia, pain in muscles, that doesn't tell us anything. Same thing with dysautonomia, impaired autonomia, autonomic nervous system. Doesn't tell us anything. POTS.
Almost feels like a symptom, not a syndrome.
Yeah. They're all symptoms. We see them as signals rather than symptoms. They're all symptoms. But if we think about people who have connective tissue issues, who are either hypomobile or hypermobile on both sides, we see dysautonomia commonly as a thing. And so now it's a lot more diagnosed and validated because there are standardized tests to look for those things. And there's standardized tests to look for hypermobility as well, right? That's done in the office. And
who typically does that? I was
usually therapy.
Physical therapy. The patient was telling me she had a much easier time getting like a concrete diagnosis of EDS through like a geneticist.
Ooh. No.
Okay, that's what
I would say this. I would say this. So some people have Ehlers-Danlos syndrome that's associated with hypermobility, and different types and subtypes that have a correlation with some sort of a gene. That's not most people with hypermobility. It's small, tiny minority.
Okay.
2 reasons. 1, we don't even know the genes. 2, the ones we know are only the ones we know, and that's it. Because when we run genetic studies, I just tell patients, don't expect to point out qualitative, but if it is, it's helpful, right? Right, and the last part is, it's not the genes, it's expressions of the genes. And it's hundreds of genes, potentially thousands. We just don't know the combination there. We don't know the combination because there's no reason to know.
It doesn't matter.
I mean, no one's making money off of hypermobility. That's the problem, right?
There's no pill for it.
I'll give you an example. Like, there are targeted gene therapies that are out there with millions of dollars of funding looking for genetic variations, right? But because there's a drug that's developed for it.
And so they've already found the drug, them trying to find a way to pinpoint the diagnosis kind of deal.
Yeah. Well, I also think that, like, hypermobility is not a diagnosis. I don't even think it's a disorder. I think it's a feature of humanity that some humans have for specific reasons. So, but the reason I think we got on this is facial symmetry. Like, if you look at facial symmetry, people with facial symmetry issues often have a lot of mobility of their skull. So, most people with hypermobility, especially in our hypermobile program in our office, Texas Center for Lifestyle Medicine, like, we're already looking for it, right? Like the nose, crooked, eye alignment, right? The way they smile, the nasolabial fold, are the folds deep on each side. And then does that correlate to when they stand up? Is your shoulder like this? Oftentimes the shoulders are really crooked, the hips really crooked. And then they usually say, oh, I was born with scoliosis, as if that's a feature. Um, it's not necessarily a feature, but it's something that's a signal of what we see could be wrong with people experiencing chronic pain issues and mobility issues. So whenever we look at people who are hypermobile, we see these big variations and outliers and different things, even in blood work, right? They generally have higher cholesterol because they actually have to have high cholesterol.
Why is that?
Well, this cholesterol stabilizes cellular membranes, and when people who are hypermobile, they usually have elastin, which is the protein that creates elasticity in connective tissues. There's derangements within the elasticity themselves, and at the cellular level, that affect the cellular level. And so they tend to release more histamine and mast cells in order just to survive so their brain can stay awake. So this is why a lot of people with hypermobility have a huge amount of what we call narcolepsy and idiopathic hypersomnia, is where the brain kind of checks out, they stare off a little bit, and they come right back in. It's literally the brain going to sleep for a sec.
And that's something you see when you do your brain storage.
Yeah, when we do the EEGs, we see significant hypersomnia in patients with hypermobility, a good 1/3 of them, right? And so I say 1/3 because we actually do data collection with a sleep neurologist. And so the hypersomnia, I think, is also a feature, even if they're diagnosed with narcolepsy. A lot of neurologists will disagree with me, but that's okay. Narcolepsy can get better. Idiopathic hypersomnia can get better if we pay attention to the physical structure of the body. The spine is more aligned, the fascia is more released, right? And the elongation, the particular fascia, and the stability. A lot of people who have hypermobility are afraid of high range of motion, right? So shoulders popping out or wrists being too extended, and elbows as well. Especially if they grew up doing ballet and gymnastics and stuff like that. And so the problem with, I think, just looking at physical therapy, pelvic floor therapy, occupational therapy, or even like just Pilates and yoga, alignment and stuff like that, we just look at that. We're actually missing the skull part, and that's what I really noticed. Is that no one's really addressing the teeth, right? The teeth, maxilla, the mandible, and the way that the head and neck is put together.
Yeah, and the reason that, to kind of expand on that concept of like what's happening with BT, which is super important. I work with like BTs and chiropractors all the time because I can't fix a person alone. Like, we're trying to help them. It takes a tribe. However, if you just treat the downstream effects, what's happening is the body, and this is something that comes from the world of chiropractics, but that's becoming more accepted in more, fields of medicine, is the body is a kinetic chain, which means there is movement that kind of propagates through the physical body. Well, the kinetic chain opens in two places. Most people are familiar with the first one, which is the arch of the foot. If the arch of the foot has what people like, which is called arch support, you're actually less strong. And that's why people who wear barefoot shoes that do not have arch support, because we've been conditioned that you need arch support to be stable. Well, if you just abandon the arch support, you're going to be in pain for a little bit because you're not used to that. But eventually you get to a place where your muscles support your arch, so that space now is opened. And that's why people will tell you, oh, once I switched to barefoot shoes and I got used to them, I can squat more, I can deadlift more because they're able to exert more force. So that's the first place that kinetic chain is open. The second place is the space between the teeth. And I've seen it. This person gets adjusted, or they do craniosacral therapy, which is literally gently manipulating the skull plates to bring them into more symmetry. And the moment they bow down, they're right back at it, because the kinetic chain closes again and they go back to their old pattern. So it's really interesting. So those are the two places where the kinetic chain is open. And if you're able to control the opening in the mouth by a specific appliance, putting pressure only in certain spots, And then those other interventions like the PT and the chiropractic adjustments get more sticky, as in instead of having to go every week, now progressively you can go every other week and maybe once a month and still feel just as good.
No, that's interesting. And that makes sense. Because I guess that also involves the pelvic floor. Because your arch of your foot, the palate, the bite affects the engagement of the diaphragm and then the pelvic floor, right? And so it's one big thing is this condition called interstitial cystitis, which is a diagnosis I was never really comfortable with, not comfortable with treating, but comfortable with like why it actually happens. In med school, it's like, yeah, it just happened. See, inflammation of the bladder, here's some medication. And we're on the boards, it's like there's one question on interstitial cystitis, and yeah, you treat it with, intrabladder BCG, which was used as a treatment and vaccine for tuberculosis, and then that was it. That was all med school. And then in practice, it's like, oh man, a lot of people have interstitial cystitis.
So what are the symptoms for that typically?
It feels like urinary tract infection without actually having urinary tract infection. But then you talk to the pelvic floor people, they're like, there's a huge amount of pelvic floor engagement in the bladder that's seemingly inflamed, and it is inflamed, has to do with more of the mechanical positional issues with the pelvic floor. And then so is prostate enlargement in males. How many men have prostate enlargement? Quite a bit. That also has to do with the pelvic floor as well. And the pelvic floor therapist is like, yeah, they look at the mouth. I'm like, why are the pelvic floor therapists looking at the mouth? Well, to look for signs of like grinding and wear because your pelvic floor is supported by your diaphragm as well as your pelvic. I'm like, oh, okay, well, this is interesting. And uh, and then I asked my mom, who's the acupuncturist, she's like, oh, how do you not know this? Did you not learn this in school? Absolutely not. Absolutely not. And so now when I got to start training in functional medicine, I like to tell people when recovering functional medicine doctor, functional medicine is on another level of trying to explain biology and chemistry, also without necessarily looking at the physics. And there's nothing wrong with that because that's how we're trained. But when functional medicine, we have these concepts in functional medicine of methylation. So methylation is putting on chemistry, putting on methyl groups, CH4 groups, methyl groups onto different parts of our code, our genetic code, and they will switch a gene, not on and off, we're left and right. Which way does the gene go? Left or right? Right, this way or that way. So this concept of methylation, which I dove deep into, are features of some people having genetics and something called single nucleotide polymorphisms, or something called mutations, not really mutations. And there's this thing called the celebrity gene. It's called MTHFR. Okay, and for
What is it called, the celebrity gene?
Because everyone talks about it, like MTHFR.
Okay, like the gene is a celebrity, not celebrities have the gene. Okay.
No, we call it celebrity gene because everyone talks about it. It becomes very viral, which MTHFR is not that important because I'm a compound heterozygote, meaning that the two subsets of MTHFR, it's on two parts of the gene. One is called C677T, the other one is C1298T. And so people are seeing these as, oh my gosh, I have this gene mutation, and therefore I can't methylate in a certain way, or under-methylate. Okay?
Okay.
And there's these other subset of genes that oh my gosh, I over-methylate. So what's happening here is we're looking at a very reductionistic idea that some people under-methylate or over-methylate their genome, and therefore they can't detox properly, or they can't activate B vitamins properly. I actually think that's a bunch of garbage. Now that I know a bit more by looking at physics. So I do think that is we see that happening in terms of what the genes correlate with. Correlation is not causation. But what else do these genes correlate with? Oral ties, fascia engagements, head and neck fascia, right? Buccal ties, right? Like this, right? Tongue ties. Okay. Well, now let's take a step back. If you have oral ties, and a lot of oral ties are associated with SDV, sleep disordered breathing. And if you have sleep disordered breathing, your ability to activate the nitric oxide pathway is less because of impaired breathing.
Because they're not breathing through your nose.
Right. And there's this cycle called the biopter and nitric oxide cycle that's in parallel with MTHFR and methylation cycles, literally in parallel. In fact, they depend on each other. Then wouldn't these genes that correlate with the oral ties stop the methylation cycle because literally the oral ties? That's a possibility. And so what we see are, once again, effects of what's going on, not necessarily like causation. Because 40% of like the world have MTHFR mutations, which means that's normal, right? And so
Or just common, but yeah.
Yeah. Well, normal means within one standard deviation of a population, 1.5 standard deviation of a population, statistically. That's what we're supposed to call normal. But no longer is that standard deviation normal statistically. So normal is whatever the heck these institutions say is normal now. You know, 60% of inner city kids in this city of Houston is neurodivergent. Well, that isn't neurodivergent. It's neurotypical, you know?
So if it's 60%, it's
Yeah. So either, ADD, ADHD, OCDs, some sort of thing, right? So that's neurodivergent. And so what are we actually calling normal? So on social media, I hear this thing called normal, and it bothers me because, like, if you're a statistician and you hear the medical industry call something normal, I was like, well, is it within that standard deviation of the 50 percentile, right? And so once again, if these things are normal, then there should not be a D at the end of the word. ADHD, disorder. The disorder shouldn't be there, right? PTSD, post-traumatic stress disorder. Why don't we just call it, there's a deficit? It's not necessarily a disorder, but maybe a feature of what's going on, right? So the way I look at people with autonomic dysfunction and people with these seemingly cryptic diagnoses, such as chronic fatigue syndrome or neuralgia paresthetica or dysautonomia in POTS, is that they all come from a compensation mechanism of the body required to be in fight or flight, and survival mechanism for something that's going on. And oftentimes there's a physical feature, physical manifestation, usually with craniofacial issues, sleep disorder breathing, scoliosis, pelvic floor issues. There's a lot of physical things that are going on. But as a physician, as an MD, who is, funnily board certified in internal medicine, the external medicine is a lot more important to observe than what we see from a biochemical process. There's a term that I don't know if it exists, but I'm gonna call it. You may hear it first. It's called scientific bypass. So scientific bypass is very similar to spiritual bypass. So spiritual bypass are people who are so spiritual, they're the big manifestors, and they will just believe it's happening, and then and therefore everything that's problematic is bypassed by the spiritual. That's called spiritual bypass. But people who are truly spiritual can recognize spiritual bypass and say, hey, like, the idea of spirituality is to find reason and take action on the reason, not to find reason and then dissociate your reality from the spirituality.
Not my problem.
Exactly. So that's called spiritual bypass. Scientific bypass is, I would say 90% of the stuff that's on social media that says, science says this. Here's what we see in science. This is a new trial that came out that says this. Okay. Now I do that too. I'm on social media. We usually have a theme to it. Is that okay? Well, the new trial says this. This is what we actually see. And what happens is people start bickering in the comments section.
Because it's not evidence-based or blah, blah. Like if it hasn't been proven yet, well, it doesn't mean it doesn't exist. We thought the earth was flat for a long time.
Well, here's the case. The earth is flat because if you just look down my driveway, it looks flat to me, right? So I'm also right. But at the same time, science was never meant to be something to be proven. Science is meant to be disproven. So, and that's what's messed up, is that the whole concept of the development of science is a reasoning for spiritual discovery in the first place. So science is a tool for spiritual discovery. That's the whole design of science. Okay.
What do you mean by that? Expand on that idea.
All right, let's look at astrology for a second. So look at astrology. It looks like the stars like moving and the moon's moving, right? And then you look at patterns. You're like, oh, maybe we're moving. And so what happens is this pattern recognition usually has a theme to it of a reasoning. Right? And so let's say if the stars right there, the Orion's belt, right? And I was like, oh, Orion's belt always staying together and it's like shifting. Let's make monuments that correlate with that. All right, let's make Stonehenge. Let's make the pyramid of Giza. Actually, the 3 pyramids. Right? They aligned exactly with Orion's belt in true north, at that time.
Yeah.
Okay. So let's make things that we can ground in concreteness, so that we know that Orion's belt is always kind of there, shifting on its own, and it's not moving away from each other. And so astrologically, humans have said that, okay, well, this must be a sign of the gods, and therefore gods are scientific. So, but the purpose of science is to be disproven, so that like someone else can come in with that idea and say that I'm going to challenge that idea. And scientist says, please do. Let's sit down and debate and philosophize. You don't have that on social media. You have I'm right, you're wrong. Okay? And so, and I think that's the natural consequence of what happens when we are educated in institutions that says that this is right and that's wrong. Whereas this is what we think is right, but be open to providing that this is wrong. PCOS, oh my God, such a great example. Polycystic ovarian syndrome. Now it's called multiple endocrine something. I forgot what it was. But the word cyst is gone because it has nothing to do with cysts in the ovaries, right? And so we're seeing the community like move. 2014, I got my Facebook disbanded, or actually shut down, because I said that type 2 diabetes can be reversible.
Well, not everyone accepts that.
Everyone accepts that, right? And so even the American Diabetic Association says, hey, if you want to get your A1C down with lifestyle diet, here's the actual recommendations. They literally have a guideline.
Fast a little bit and just do this and that. And
so what's happening is that we are seeing things that the bigger institutions will kind of cherry pick to see what's acceptable and say, hey, this is now acceptable, right? Now, 3 years ago, if someone says, I just saw a UFO, people are like, no, you're crazy. What's happening in 2020? Like, oh yeah, the Senate just had a hearing about a UFO.
yeah,
Right. Let's talk about that. Now it's more engaged. People are starting to accept it. Right. 6 years ago, ayahuasca was not even a thing that people even talked about. I was like, what is this ayahuasca?
like, oh, it's just some druggies doing some stuff up in the mountains or something.
Right. And now it's common knowledge that ayahuasca and other psychedelics are utilized in all major religions, and even prehistoric times, of people having similar visions all over the world because their art becoming similar, from stained glass windows to the caveman drawings and the creation of fairy tales, the gnome, the fairies and stuff. These are all like psychedelic visions that are consistent across all populations with.
Because we're a lot more interconnected than we would like to believe.
Exactly, right? And so now it's like a thing, right? And so these things, conveniently, when someone creates a technology to monetize it, right? Then we becomes acceptable, right? Another one is focused ultrasound for Parkinson's, or TMS, transcranial magnetic stimulation for depression. What is that? That's literally energy healing and PEMF therapy. That's what it is, right?
Proteus was something,
Yeah. And so, and focused ultrasound is sonic frequency, so sound healing. Focused ultrasound is sound healing. These FDA approved modules, modalities for like now Parkinson's and stuff, right? And so going back into this concept of, I'm tying this back into what we're talking about, which is fibromyalgia, dysautonomia, it was Down syndrome, hypermobility, um, facial pain, trigeminal neuralgia, vertigo, pelvic floor issues. Okay. All these things are mechanisms of a cranial facial structure that we're able to observe that has a downstream effect of the head and neck, the diaphragm, et cetera, et cetera. So we have to take a step back, even in the field of functional integrative health. Like, we have to take a step back and say, hey, all right, now that we know this, like, how do we tie and correlate like all these things together? And I have a distinct vision of what medicine really should be like, and it's to go back to the ancient times and observe our body as if it's astronomy. Okay. And instead of looking at Orion's belt, something in the sky, look at it as, C8, T5, and L4 in your spine, right? How are they aligned together, right? If they're shifting and they're off, then should we anchor on them supposedly being a lot more aligned than it really is? And so I think that there is an advantage for all diseases. There's an advantage for diabetes. There's an advantage for autoimmune. There's an advantage for hypermobile EDS. There's an advantage for mass activation. And the advantage is that allows humans to look at us to see what are we actually anchoring to. What is our anchoring reality?
So how do you explain that advantage to a person who's suffering from one of these conditions?
Well, first of all, let's talk
Not suffering very specifically,
Yeah.
because some people have it and they
Yeah.
have a whole lot going on with it.
Yeah. Suffering has nothing to do with conditions. Suffering is a perception, is a relative perception. In fact, this person at one point had to be so happy that they're suffering a lot, because it's relative. And so what happens is what we see, these conditions is picked up by this one story. So I was on this social media site called Asymmetry, which is a social media for physicians. And there's this ER doctor that says, I'll never forgive myself. I had this patient, and this patient came into the ER, blood sugars through the roof, and there's major angiopathy, which is basically blood vessel deterioration in the limbs. And he's like, hey, you don't come back, like that leg is going away. And the patient said, you know what, I'll treat myself, and I'm going to go to Mexico, get some stem cell treatments. And a few months later, the patient came back to the ER, once again, high blood sugars, but the leg is already gone. It's already amputated. And the ER doctor is like, oh, I blame myself so much for this patient. And so, you see in the comments a lot of like sympathies and stuff, right? From other ER doctors, surgeons, orthopedists, right? And then my comment was, how do you know that this patient didn't go on the absolute best journey of their life, discover their best selves, got in touch with the people in their lives, have really amazing relationships, and that's worth more than his leg that you see. Okay. So you, the ER doctor, are suffering because of a perception of a responsibility that you took that may or may not be necessarily true, may or may not be congruent with the suffering of the other person. And so I think that the term suffering, it's all relative. But let's say that like this person has pain, and then we as doctors, we perceive the pain as coming from hip, diaphragm, something like that, right? And maybe that can contribute to and correlate to it. But I'll tell you, like in the field of functional integrative health, a lot of times that's corrected. The pain gets worse. The perception of the pain gets worse. Let's say they have sleep disorder breathing, that gets treated. Maybe they get jaw surgery, maybe the appliance, maybe they have like spinal deformity issues, that's corrected. And so what happens is that we see this as the remission effect. All right. A remission effect is that, oh, your symptoms went into remission, and therefore you're waiting for the next shoe to drop, because that's the pattern that you've seen in your life because you've been living with this condition for so long. Okay. Similar, someone with breast cancer, okay. Targeted therapy, chemotherapy, rang the bell at MD Anderson, I'm done with chemotherapy, I'm in remission. The minute they go into remission is the most depressed they often feel in their life. It's the remission effect. It's because they're waiting for either the cancer to come back or another cancer to come. And so what happens with this thing of suffering is, first, we as practitioners have to practice our intuition. Like, well, why is this person really suffering, right? And oftentimes in the world of like chronic fatigue and dysautonomia, Lyme disease, and mold, we see like self-relation issues, like relationship with yourself. And there's a perception of something that's there. And so psychiatrists pick this up. Psychiatrists can pick up on word patterns of people who, when they get better, they don't really get better. Psychiatrists, psychologists, licensed social workers, like they all pick it up, right? And so what happens is, so the role that I play then is if I see it, can I reframe it? And the beauty of what I do is I look at brain mapping. Okay, well, so I can tell someone is have a perception of suffering. I can tell someone's having a lot of like sensory coming in. I can tell someone's an empath their whole life on these brain maps, right? And so now I play a game for the patients who are listening to me. I do this with you. When I first meet you, I tell you, you don't tell anything about, you don't tell me anything about you. I start predicting like what your life has been like. And they're like, oh, just look at the brain map. And it's because like these patterns of human emotionality and like electrical signaling does this in the brain as a perception. So what I would tell for patients who are quote unquote suffering from these conditions is this: let's say that you're in a lot of pain, a lot of discomfort, a lot of fatigue right now, brain fog, right? And I want you to imagine this. I want you to imagine that you're on your deathbed. So you're on a deathbed, and there's family around you, or friends, or maybe there's nobody around you, and then you're at peace with your death. Then do these symptoms, are they still affecting you if you're at peace with your death? This is this concept in Buddhism called death meditation. Is that let's imagine yourself on a deathbed, how it smells, how the sheet feel on your skin, the people around you, and the concept of death meditation is actually bring life into your current life. Is that if I was going to die, will this matter? Will this matter? Will this matter? Will this matter? Right? And you start detaching from the outcome of this and this and this and this and this. Your perception of pain actually gets better as well. Even if you have a herniated disc, even if you have whatever. So the co-founder of my app, Superconscious, Tommy, that's his story. He was told that he had this herniated disc playing basketball. He played basketball at Harvard, and he was great, amazing athlete. And then he was told that ultimately that he had this herniated disc and he was in pain like every single day. And then he discovered this guy by the name of John Sarno and did the Sarno method, which is basically like using your desired reality to create your pain-free life. And so so a lot of it is that, oh my gosh, you are the placebo. And then he did these methods, Dr. Sarno's method. I think he said 2 weeks, and after that, he's like, he has no pain. Did he still have the herniated disc? Yeah.
There's perception type.
What a perception change, right? And I mean, he's still good now. He's doing Pilates and all sorts of stuff and no issues. And so that's the whole concept of our app, Superconscious, is that you can actually create your reality and truly understand it. But then we can't tie the suffering to a diagnosis, because that's where science becomes flagrantly overplayed. So many studies on this. My sister, who's a radiologist, she'll tell you that, like, ethically speaking, she has a hard time calling a lot of the things on the imaging, whether it's a disc herniation or something like that, is because of the fear that people will see that, oh, I've herniated this.
Now they have this reason to
Now they
stuff.
really have that pain, right? The placebo came, and now they really have that pain. And so what happens is that the pain and suffering is there, but we in the medical institution have now just given it something physical to
anchor
it on. We just gave it the Orion's belt, right? We just gave a human the Orion's belt to anchor the reality. Hey, Orion's belt, not moving in the sky. We must be rotating and not the stars, right? It's like this. Okay, now you herniated this. So what happens is this happens in all of medicine. It happens in dentistry, I think, especially what we call TMJ issues, which also bothers me.
The whole TMD thing is
right. So like going into like the TMJ disorder. Now TMJ disorder dysfunction, like that's the reason I avoided dentists my whole life, is it will lock up and I'll be the worst pain in my life if my jaw locks up, right? Used to. And then so what happens is that a lot of people say, oh, I have these TMJ issues, I'm clenching a lot. My dentist tells me I must be stressed and I'm not clenching a lot.
I just had that conversation last night with someone who's, well, yeah, I gland, but I'm stressed all the time, so it's okay.
Yeah. And so,
is it?
Yeah. But stress is not okay. That's stress is the number one cause of death in the world. Number one, right? And number two, the Western perception of stress is that I'm going to think my way out of it. It's actually not true. You can't really think your way out of stress.
Not a logical problem.
Yeah, it's a subconscious, not a conscious problem. And then thirdly is that, yes, the stress compounds with your body wanting to stabilize symmetrically. So you're trying to find a good place to clench. And you have nerves from the maxilla and the mandible feeding back to this hypothalamus, telling the vagus nerve to activate and calm down. But it can't because like things aren't clenching together. So what happens then is that I see people who then get diagnosed with TMJ issues and they get Botox infection or Botox injections, and masseters in parts of the neck, and they feel better. Oh yeah, it worked like a charm, feels better. For 3 months. And after it stops, right?
Well, this is, I think me and you have talked about this from where you bring up the Botox piece. So usually with those people, and I mean, if you're truly better through, I'm happy. Usually I'll ask them, okay, you did the Botox. And if it's not recent, I usually tell them, like, if you have an O-ring or something, go back to that. But if not, just mentally try to go back to that times. And as your facial pain started getting better, what happened in the background, I don't tell them this right away until we're done having the conversation. What you're doing is you're taking your body's ability for the compensation that's trying to protect your airway at night. I say, as the pain subsided, do you feel like you were more tired? Because what happened is now they don't have the compensation mechanism of the clenching to keep their airway open. And they go, oh. And in their mind, they justified it as, I probably was tired also, but I was in so much pain that I wasn't perceiving the tiredness because the pain was clouding that. Right. What really was happening is they took away their compensation. So now physically they're worse. There's no pain, but they're more tired because the body doesn't have that compensation. Another theory, and I mean, science hasn't proven this, but a lot of these people that, increase or have a tendency to clench when they're awake, when they're perceiving stress. If this person has sleep disorder breathing and their body doesn't understand the difference between a tiger in the jungle or your boss being, upset with you because you didn't get something done. All stress is stress to the body. Well, when you're asleep and if your airway's starting to close up or your oxygen levels are about to drop, and your body does its beautiful thing called airway protective reflex of clenching to open up your airway. Now your body and your mind are programmed to understand that every time I clench, I get stress relief. So it's a learned habit.
Yeah, that's true.
So then during the day, you get the psychological stress that has nothing to do with your airway, but your body goes, oh, I know this cool trick. Let's clench and see if it gets better.
So daytime clutching is a Pavlovian response from fine protection.
That's my theory.
What? Let me think about this. That's possible. So maybe you're right. Maybe daytime clenching, like what right here, is part of it. You know, what I always thought is like clenching is you're bracing for impact, right? You're getting ready to be hit, or you're about to like pounce on something. But potentially, yeah, potentially it could be a Pavlovian response. I shouldn't say Pavlovian. I would say it was a learned mechanism response of someone trying
That
to.
got reinforced in an unconscious state.
I could see that. And so like you're going back to the concept of suffering is what you said is you had a reframe. It's like, well, there's suffering and pain. There's also suffering and energy. And when you suffer in energy, that turns into mental health issues, pain as well, but specifically energy, because most people don't realize they don't have energy. Right?
Well, because you can get a Red Bull or you can chug like
Yeah, Red Bull,
and
Adderall, Vitamin.
Adderall, vitamins. You have all these things to compensate for, and this is
Yeah,
another interesting thing, and that's why, like, chronic pain is a much bigger market than chronic fatigue. You can stimulate your way out of fatigue, but you can't stimulate your way out of pain.
yeah. Interesting.
There's only so much you can take while still being able to drive and go to your job
There's
or
there's one way to stimulate yourself out of pain. It's social media scrolling. That's a high dopamine hit that can actually stimulate your way out of pain. So a lot of people with chronic pain will get other phones and just scroll endlessly because they're actually in pain. And so it's just it's the dopamine effect of the brain, right? So I do think that like I mean, let's face it, people make money from social media scrolling, right? And so I would say that like our concept of suffering has to be kind of redefined into categories. Categories such as pain, categories as energies, but most importantly, categories. The most important category I think is self-love. If you're lacking a lot of self-love and there's guilt that comes with it, potentially it's because your body is not able to regulate itself properly, whether it's breathing well, it's functioning well, et cetera, et cetera. And potentially that's been going on for so many generations because airway disorders, sleep apnea, central breathing is hereditary, that it's been normalized in multiple generations.
so you grew up just knowing that that's just part of how it is.
Yeah. It's kind of like schizophrenia. Schizophrenia is a mental disorder, usually with auditory hallucinations, right? Hearing things, people, voices, etc., etc. A big part of schizophrenia actually has to do with body's pain mechanism, compensation mechanisms, and dopamine activity. And they say that, like, okay, if you have schizophrenia, you have auditory hallucinations, then if you have family history of it, then that could be a hereditary thing. But with schizophrenia, we learned there's a lot more to schizophrenia. There's inflammation in the brain that's correlated with schizophrenia. It's like actual inflammation. It's not just like hearing voices, right? Especially in the temporal lobe. Schizophrenia highly correlated with periodontal disease, yeah, sinus abscesses and stuff like that, jaw fractures and stuff like that. And so it's like, whoa, okay, you know. And so now it's all about the grounding reality in which we're speaking from. And I think that so airway medicine right now, like airways through disordered breathing, is one of the most viral like themes in medicine. Probably the most viral theme in medicine right now. That plus POTS and dysautonomia, which hilariously they're often
They're not connected.
yeah, they coexist, right? And so but it used to be Lyme disease, mold, and fibromyalgia. But now it's like POTS and dysautonomia, mass activation, and then airway disorder, sleep disorder, breathing. So I think we're just having new fancy names for things that we are observing in humanity for quite some time. But the problem is like the way that medicine's taught, especially in med school and residency, is like they're taught as different things because you have to get insurance to approve some treatment modality for one thing or another, right? Like if I diagnose someone with dysautonomia and I try to order physical therapy, it's not gonna be covered. You know, I have to say polyarthralgia with maybe fibromyalgia, chronic lower back pain, shoulder pain, issues like that. I have to have a put a list of 9 different things to attempt to get Blue Cross Blue Shield United to cover the physical therapy. And the physical therapist is like, well, you want us to continue, you have to go back to your doctor and get diagnosed with this different set of codes, right? So we become a triage, a secretary of diagnostic codes, and that's what medical dental has honestly become over the years, right? And most people don't know this, but whenever they're seeing me or any of my staff, I am literally jotting down mental notes of diagnosis codes as they're speaking, because that dictates what labs I can order for it to be covered by insurance.
Right. You're doing it to help the patient out and kind of optimize what they can get.
But it's mental fatigue. It's mental fatigue, and oftentimes I'm trying to extract information from the patients, right? And oftentimes the patients say, "No, I'm okay here. I'm okay here." I'm like, "All right, listen to me. Listen, I want to help you out. I don't want you to upplay or downplay your symptoms, but this is my screen on my computer. I'm literally putting in diagnosis codes to get as much lab and therapy coverage as you can get. And so don't make up symptoms, but tell me, like, you say you're not that fatigued. Are you really fatigued? He's like, if you're talking, I'm actually pretty tired, and that's not even told everybody, right? I'm like, great. And so that's what a lot of the P4 are actually. That's why we're getting to this nomenclature is that like for predisposition of a diagnoses, we have to put in symptom diagnoses, and all of a sudden, like, the diagnosis list like this long, and then that goes into the insurance companies, and then the patient goes to the ER, and the ER doctor says, "Oh my God, there's like 46 things on the diagnosis, right?" And immediately there's a preconceived notion that's there. You know what I'm saying?
Yeah, which is typically, ooh, this person is unwell.
Yeah.
And they don't even meet it in the physical life a lot of times.
No, and so like we've reached this point of medicine where, yes, we're talking about like Ehlers Danlos and hypermobility and polynomial and muscle activation syndrome, fibromyalgia, chronic fatigue syndrome. We're talking about it in the way that the systems are like correlating together. But in order for it to exist, especially in the United States with the insurance and ICD-10 diagnosis codes, oftentimes it's not even reflective if in our notes, because we have to get the insurance on board, to pay for the sleep study, to pay for the physical therapy, to pay for the occupational therapy, right? And it becomes a big issue. But I think the biggest missing link, honestly, has been sleep disorder breathing, by far. Yeah.
Yeah, the whole sleep thing. And I know some people are a little more sensitive to the whole like sleep medicine concept because they feel like it's been oversold or overplayed in a way. And the concept that I like reminding people of is sleep is so important, and it has survived through our evolution over thousands of years. It's such a huge disadvantage. 6 to 8 hours, you're completely vulnerable to a predator out in the jungle. It survived because it's that important. And if we don't get enough of it or good quality, then your body will just deteriorate. And it's becoming probably harder and harder now with all our screens and technology and all those things. Versus in jungle, yes, you have to worry about the predator, but that's it. There is no blue lights zapping you in the eyes. There's no dopamine crashes and all of that from doom scrolling and things like that. So it's an interesting one to just say, like, take a second and think about this. How important is this that 1/3 of the day you're vulnerable, but evolution decided this is important and it's staying?
Yeah. And also, back in the day, you chewed a lot more, right? There was no Gerber.
No, everything was hard.
Yeah, so you stimulated your skull growth and stuff like that. But then again, back in the day, the average lifespan of a human, like Homo sapien adults, was 28 years old, right? And so made it past 28, that means that we're in this no man's land of what actually happens. And then aging happens, right? Airway disturbances, spinal deformity changes, et cetera. And people were like, "Oh, half of men's testosterone starts decreasing after the age of 40." I'm like, well, maybe that's That's because like we've survived past what we were meant to be. Yeah. And so we have to create a new reality. And what does that really look like, right? That could be optimizing breathing, using breath work, doing exercises, Pilates, yoga, Tai Chi, Qigong, mindfulness. These are mechanisms that are divinely orchestrated so that humans can utilize these tools, connect greater with God and connect greater with themselves, with ourselves. And so we have to view everything right now as a gift because we're in this bonus zone, right? And people talk about longevity all the time. Longevity has less to do with the length of time, more to do with the perception of length of time. You can have right now we've been talking over 65 minutes. It didn't feel like 65 minutes. It's because it was short, but that's my perception, right? But my timer says 65 minutes. And so sometimes, if my daughter was sitting here, she'd be like, oh my God, I'm so bored. You guys are still talking.
Yeah.
Right? It's just like, it's been like 8 hours. Like, no, it's been 65 minutes. And so there's a perception of time and the quality of life that we have to grab at. The problem is people think the quality of life is science-based. It's actually faith-based. It's not science-based. Faith in ourselves, faith in something greater than ourselves. That's what determines the true quality of life. The studies that's done on this. The people with the best longevity and aging gracefully, they have the biggest faith. They come together in community congregations and stuff like that.
And that's the thing. It's the community part of knowing and believing that it's going to be okay. And if I fall on hard times, I have someone I can lean on, and I know I can depend on it.
Yeah, absolutely. So, in concluding this, what do you think are the 3 most important things that you wish everyone knew about their face?
Your face is asymmetrical, as in your eyes, all the different levels. Just try to stand in front of the mirror as straight as you can and just look at your eyes. Or is one level or one brow a little higher than the other? You won't be able to see it on the internal corners, but you'll see it on the external corners of the eye, or you can see in the eyebrows. Or if your ears are on level, that means your skull is in this strained pattern. And the way I try to explain it to patients is our skulls have these sutures that people thought for years that they don't move. Well, that's been disproven now. And your skull is doing this breathing movement. And if your eyes and ears are on level, then the reality is that breathing motion is limited because it's strained like this and it can't do the full motion now. And that means your brain is living in a suboptimal environment because the fluid that's around your brain doesn't get exchanged as efficiently. It still happens, but just not as efficient, which means if your face is asymmetrical, you're not giving your brain its full potential.
Well, that's interesting. Okay. Well, that's number 1.
Yeah.
What's 2 and 3?
Just because you're asymmetrical doesn't mean you're stuck with it. It's very much something that can be hugely improved with a removable appliance that's, for the most part, literally just pain-free. There's no surgery, no cutting, no drilling. And it's just something you put in and out of your mouth, and your face can get more symmetrical. There is symptoms that are improved with it. It's a nice bonus to have a little more symmetry or eyes and perceive, more symmetry as more beautiful.
Mm-hmm.
So that's number 2. It's just, it is possible and it doesn't involve surgery.
At any age?
Any age.
Any age. Okay.
Wow.
What's number 3?
That's it. I feel like those 2 cover most of it. But just start paying attention to your body, as in when you walk, are you wearing out your shoes unevenly? As in, like, you just pick up a shoe you've had for a couple of years and you look at it, and then look at the wear pattern. Is it the same? If it's not the same, you are doing more wear and tear that's asymmetrical in your body. And then look at your face and see if you see a connection there. Because this is the other end of your body, is your feet.
Yeah.
If you are doing that in your feet, that means whatever is going on in your face has gone so far downstream as it's at the ground level at this point. And I'm not saying, again, the adaptive range can be different depending on your life conditions, but if those life conditions change and you ignore the physical aspect, you will have a lot more to deal with. So even if you're not having major suffering with this, it's worth at least exploring, because life conditions can change. No one can control the life conditions.
Yeah.
But you can control your physical condition to be prepared for what life might bring to you.
Okay. Amazing.
Thank you.